Welcome to the deep dive. We're here to take these really big foundational ideas today. It's the core models behind modern patient care and, boil them down to the essentials you need, fast and clear. We're trying to get beneath the surface of what really goes into providing that comprehensive care.
That's right. And when you look at the source material for professional practice, it's really obvious that giving safe, holistic care takes, well, a huge amount of skill and very systematic knowledge. It's not just about being kind. So we're distilling it all down to two key concepts you just can't ignore: clinical judgment and systems thinking.
Okay.
Pretty much everything else, safety, quality improvement, teamwork, it all sort of revolves around these two. They're the pillars.
Got it. So that's our roadmap then. We'll start with those mental skills needed for, individual patient decisions, and that includes the big model for clinical judgment. Then we'll pivot to systems thinking, understanding the huge context, the whole healthcare environment where these decisions actually happen. And we'll finish up by connecting it all, looking at how individual actions can actually lead to system-wide improvements in quality. Sound good?
Sounds perfect. Let's jump in.
Okay, so let's unpack this. The individual mental architecture first. Our sources talk about three distinct skills, but they're really, really intertwined, essential for every decision. Let's start at the base, critical thinking.
Right. Critical thinking is your logic base. It's defined as the skill of using rigorous logic, reasoning, to sort of figure out the strengths and weaknesses of different healthcare solutions or approaches.
Okay.
If you don't have that, you get safety lapses, errors happen.
Yeah.
It's predicted by things like, well, caring behaviors, yes, but also self-reflection and insight. It's the foundation.
And that thinking, it's not just happening in your head in a vacuum, right? It needs to be informed by actual standards.
Exactly. That's where the QSEN competencies come into play.
QSEN, quality and safety education for nurses.
Yep. That framework gives you the essential knowledge, skills, and attitudes that have to feed into your critical thinking. It guides safe care.
So what are those?
Well, QSEN lays out 6 key areas: patient-centered care, safety, evidence-based practice, EBP, informatics, teamwork and collaboration, and quality improvement, or QI.
So when you're critically thinking about a solution, you can't just think, oh, this seems best. You have to run it through those filters.
Precisely. Is it safe? Is it based on evidence? Does it involve the patient? Does it consider the team? You need all 6 lenses.
Okay. So if critical thinking is the foundation, the knowledge base, then clinical reasoning is what? The engine. How's it different?
That's a good way to put it. Clinical reasoning is the active process. It's how you actually take those critical thinking skills and apply them, moment by moment with the patient.
Right.
It's the process where you're collecting cues, processing that information, making a plan, implementing interventions, and then evaluating the outcome. Think of the nursing process: assessing, analyzing or diagnosing, planning, implementing, evaluating. ADPIE or API. That's clinical reasoning in action. It's that constant cycle.
Okay, so you've got the foundation, critical thinking, the engine, clinical reasoning, which brings us finally to clinical judgment. This sounds like the end result, like the observable part.
That's exactly it. Clinical judgment is the skill of recognizing those cues we talked about, generating potential explanations or hypotheses, weighing them up, taking the right action, and then evaluating if you got a satisfactory outcome.
Okay.
The NCSBN, the National Council of State Boards of Nursing, defines it as the observed outcome of critical thinking and decision-making. It's the result you can actually see built on those internal unobserved processes. It's kind of the ultimate measure of whether you put it all together correctly in that situation.
And then NCSBN didn't just define it, they created a whole model for it, right? The clinical judgment measurement model, the CJMM.
Yes, and that's a really important development.
What's the big deal about the CJMM? It sounds like it moves beyond just, did you pick the right answer?
It absolutely does. The huge thing about the CJMM is that it explicitly acknowledges that context is everything. It's not a simple calculation.
Ah, context. So things like how much time you have, the risks involved.
Exactly. Time constraints, the specific patient risks, what resources are actually available that could be info in the EHR, the physical environment, even the nurse's own specific knowledge and experience. It all impacts your judgment.
So, like the example they give, handling an ankle fracture during a mass casualty event is totally different than dealing with it in a quiet hospital room.
Precisely. The context completely changes the required judgment, the priorities, the available actions. The CJMM embraces that complexity.
Okay, so the model itself has 6 steps to guide this thinking. But hang on, if context is rushing you, how do you consciously go through 6 steps?
That's a great question. It's more of a mental framework than a literal checklist you tick off one by one, especially under pressure. With experience, these steps become almost instantaneous, fluid. But understanding the steps helps structure the thinking.
Okay, walk us through them.
Sure. Step one is recognize cues. What assessment data matters, what's relevant, and what's just background noise. This maps to assessment in the nursing process.
Right. Spotting what's important.
Step two, analyze cues. How do these important findings connect? How do they relate to the patient's condition or history? This links to analysis, maybe assessment too.
Making sense of the pieces.
Step three, prioritize hypotheses. Based on that analysis, what are the most likely or most dangerous possibilities? What needs attention right now? This is like diagnosis, figuring out the main problem or risk.
Okay, figuring out the biggest threat.
Step four, generate solutions. What can we actually do about it? What interventions, nursing actions, or collaborative efforts will lead to the desired outcome? This is planning.
Deciding on the what next.
Step five, take action. Go ahead and implement the highest priority interventions. This could be teaching, carrying out provider orders, collaborating, a direct nursing task. This is implementation.
Doing the thing.
And finally, step six, evaluate outcomes. Did it work? Is the patient getting better, worse, or staying the same? What signs tell you? This maps directly to evaluation. Then the cycle often repeats.
Okay, that makes sense as a thinking process. Let's make it real with that dizziness example from the source. Patient admitted for dizziness. Nurse helps them stand up.
Right. So the nurse helps the patient stand and immediately notes dizziness, maybe some instability.
Okay.
Okay, step one, recognize cues, dizziness and instability linked to position change.
Got it.
Step two, analyze cues. The nurse thinks, okay, dizziness. Could it be low blood sugar?
Yeah.
But then connects it. No, it happened right when they stood up. So step three, prioritize hypotheses. The most likely culprit, the most urgent thing to consider is orthostatic hypotension, that drop in blood pressure with positional change.
Makes sense. The timing is key.
Exactly. So step four, generate solutions. The immediate priority here is safety. Preventing a fall is paramount. What helps prevent falls in this situation?
Don't let them walk around dizzy.
Right. So step five, take action. The nurse identifies the patient as a high fall risk, decides to use a urinal or bedpan instead of walking them to the bathroom right now, maybe puts up fall risk signs, ensures the call bell is in reach, and importantly, educates the patient and the rest of the team.
Okay, practical steps.
And finally, step six, evaluate outcomes. The nurse keeps monitoring. Are the precautions working? Is the patient stable when resting? Did they avoid a fall? If yes, then that whole rapid sequence represents excellent clinical judgment in action.
That's a great illustration of the CJMM working for an individual patient. But you mentioned earlier, what if this isn't just a one-off? What if dizziness on standing is happening a lot on the unit? Maybe it's related to meds or staffing or something bigger.
Now you're making the shift. That's exactly the trigger to move from focusing solely on this one patient to systems thinking.
Okay, so define systems thinking for us.
Systems thinking means stepping back and looking at the bigger picture. It's the ability to see and understand how all the different parts of a system, the people, the policies, the technology, the environment, interact and depend on each other. It's about understanding the whole complex web of healthcare delivery, not just the single thread you're holding. Nurses really need to think globally beyond their immediate task list.
Our sources use that iceberg analogy, which I think is really helpful here. Can you explain that?
Absolutely. The iceberg analogy is perfect.
Yeah.
The clinical judgment for the individual patient, that successful handling of the dizziness case, that's just the tip of the iceberg. That's the part you easily see.
Okay.
But underneath the surface, that's where the massive bulk of the system lies. All the hidden factors that influence that visible care. Things like the overall complexity of care on the unit, the use of evidence-based practice, the health determinants of the patient population being served, new technologies being introduced, and critically, health policy and the different environments of care. All that stuff below the waterline shapes what happens at the top.
Environments of care? So where the care actually takes place, that matters for systems thinking too.
Hugely. Your systems thinking approach will look different in different settings because the systems themselves are different. We usually talk about primary care, think GP offices, the initial point of contact, then inpatient care, like hospitals where people stay 24 hours or more, and community-based care, which is a broad category including things like home health, public health clinics, retail clinics, school nursing.
Okay.
And within community care, for instance, you see specific system models designed to address fragmentation. A great example is the patient-centered medical home, or PCMH.
Right, the PCMH. Explain that a bit. It feels like a prime example of applied systems thinking.
It really is. The PCMH isn't usually a literal home. It's a model of care,
Right.
often in primary care settings. It uses a dedicated interprofessional team, doctors, PAs, NPs, RNs, maybe social workers, pharmacists, all working together very closely. The goal is to provide coordinated, continuous care, especially for patients with chronic conditions who often get lost between specialists. It focuses on specific elements like enhanced access, care coordination, using health IT effectively. It's a system designed deliberately to overcome common healthcare system failings, like poor communication.
And you mentioned the interprofessional team. That's another system component. But the source notes different underlying models of practice within that team.
Yes, and that's important for collaboration. Physicians and physician assistants generally operate from the medical model. Their primary focus is on diagnosing and treating disease, identifying the pathology, the specific condition based on anatomy, physiology, etc.
Right. Finding the cause, fixing the disease.
Whereas nurse practitioners and registered nurses are grounded in the nursing model. While NPs certainly diagnose and treat conditions, the nursing model has a broader emphasis. It stresses patient-centered care, promoting health and wellness across the whole lifespan, and diagnosing and treating the human response to health problems or life processes.
Human response, meaning how the illness affects the person's life, not just the disease itself.
Exactly. The RN scope explicitly includes caring, teaching, collaborating, advocating for the patient, and even engaging in research to improve care. It's inherently holistic and system-aware.
Okay, so we have the individual judgment piece, CJMM, happening within this big, complex system influenced by the environment and the team. Now, let's connect it back. How does a nurse using systems thinking actually change things for the better? Go beyond just fixing things for their one patient.
That's where quality improvement, or QI, comes in. Systems thinking pushes you to look for patterns, for root causes of problems that affect multiple patients. The goal isn't just to be vigilant for one person, but to implement evidence-based changes that improve the system itself, making care safer or more effective for everyone. It's like dropping a pebble in a pond, the ripples spread out.
Let's use the ventilator-associated pneumonia VAP example. The source shows how this escalates nicely.
Right. It starts small, with individual action. A single staff nurse is really diligent about following the protocol for effective oral care for their ventilated patient. They exercise good clinical judgment.
Okay, one good nurse.
But then, using systems thinking, maybe they notice others aren't as consistent, or the protocol itself could be better. So they move to systemic action at the unit level. Maybe they create a simple reminder sign to put over the bed. Or perhaps they read new research about using, say, an oral chlorhexidine rinse, and they bring that evidence to a staff meeting, suggesting a practice change for the whole unit.
Okay, influencing their immediate colleagues.
Then it can go even bigger, to the macro level. The unit tracks its VAP rates. Maybe they compare their rates to the rest of the hospital or even national benchmarks. If that nurse's suggestion, like the chlorhexidine rinse, leads to a measurable drop in VAP on their unit, that data can drive a hospital-wide policy change. Now, every ventilated patient benefits because one nurse thought beyond their own assignment.
That's a powerful progression. And the CAUTI prevention case study, catheter-associated urinary tract infections, shows this on an even bigger scale.
Absolutely. CIUDIs are a huge deal, dangerous for patients, incredibly costly for hospitals. So this hospital system used systems thinking. They didn't just tell nurses, be more careful. They analyzed the system to find the riskiest points for catheter insertion, like the ER, the OR, PCU, critical care. They saw where the system itself was weak.
So they identified system vulnerabilities. What did they do?
They implemented a multi-pronged interprofessional system solution. They educated specific RNs to become CAUTI ambassadors, champions on the units, to ensure protocols were followed consistently. They started doing interprofessional rounds specifically focused on catheter necessity, and they created a monthly committee to do a root cause analysis every single time a CIUI occurred to find out why the system failed that patient.
That sounds like a massive undertaking, getting buy-in from surgeons, ER docs, critical care.
It absolutely is. System change is hard work, but look at the payoff. The source says that over 12 months, this system-wide interprofessional effort led to a 46% decrease in CIUTI rates.
Wow, nearly cut in half.
Yeah. And that wasn't just great for patient safety. They estimate it saved the hospital over $60,000. It perfectly shows how thinking about and acting on the system is crucial for safety and financial responsibility.
Okay, that was definitely a deep dive. Let's do a quick recap. We started with those core mental skills. Critical thinking, the logic, clinical reasoning, the process, and the end result, clinical judgment, the observed outcome.
Mm-hmm.
We unpacked the CJMM, the 6 steps, recognizing cues, analyzing, prioritizing hypotheses, generating solutions, taking action, evaluating outcomes, and really stressed how context shapes everything.
Right.
Can't forget context.
And then we shifted to the bigger picture.
Yeah.
Systems thinking.
Mm.
Understanding the whole healthcare iceberg, the environments of care, the different professional roles and models, and how all that connects to improving the system itself through quality improvement, like we saw with the VAP and CAUTI examples, linking back to those QSEN competencies, safety, QI, EBP, patient-centered care, teamwork.
Exactly. It all ties together.
So maybe a final thought for everyone listening. Remember that iceberg. The direct nursing care, you see the actions taken for one patient that's vital. It's the visible part. But so much crucial work happens below the surface. That commitment to looking at the whole system, analyzing the data, pushing for evidence-based changes through things like QI initiatives, that's what fundamentally changes the care that becomes visible at the tip of the iceberg. Nurses are often right at the forefront, modeling both sharp clinical judgment and that essential systems thinking. They shape the care for everyone.
That's a great point to end on. We really hope this deep dive helps you connect those dots between what happens right at the bedside and the much larger strategies and systems that shape healthcare. Thanks so much for joining us today.